This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe. Support for this podcast is provided by Allergan, an AbbVie company. We've been creating innovative products and services for our providers and our patients for over 70 years.
Ocular surface disease. It's complex, chronic, and progressive, but rife with opportunity for the enterprising optometrist.
The mission of this podcast is to make this condition more understandable and accessible to those interested in specializing in it. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host Leslie Odell. And we are very happy to have a guest with us today to talk about Tyrvaya. So please welcome Dr. Tom Kislan. He is the founder and medical director of Hazleton Eye Specialists, Stroudsburg Eye Specialists, Pottsville Eye Specialists, and the Dry Eye Clinic of Northeast Pennsylvania. Dr. Kislan lectured extensively on ocular surface disease, omega-3 science, ocular surgery co-management, and contact lens complications. Dr. Kislan also participates in clinical research, including FDA trials, most recently the phase 3 trials for Vuity. Dr. Kislan also hosts a syndicated TV and internet show titled Eye Care Today. Hello, Tom. Welcome.
Hello. Thanks for having me. This is great.
Well, I'm super excited. I don't think I even told Jackie that Tom and I are in the opposite sides of Pennsylvania, but he's long since been sort of a leader and mentor to me in the dry eye space. So it's super cool to have him on today.
Yeah, I appreciate it. This is great.
I didn't realize that you were in Pennsylvania too, but I should have known that because I was telling you earlier, we had met at a conference one time and you were so kind to suggest to welcome me to your office if I ever wanted to do like a little tour of how your dry eye clinic runs. So that's great. 2 really amazing doctors in the state of Pennsylvania.
Yeah, just the mentor though thing makes me feel old. So
no. I mean, you're not that many years older than me. I feel like you were doing it though at the same time I was starting to get ready, to do dry eye. So, and there weren't many people that were paying attention to dry eye, if you remember, right. At the beginning of it all. Yeah, at the beginning of it all. He goes all the way back to the beginning of eye care.
Right, exactly. Right.
Just kidding.
This is getting worse. Well, today we would like to talk about Tyrvaya and your experience with Tyrvaya. Leslie and I were speaking about this, and we know you've prescribed quite a bit of it, even though it was a very recent FDA approval. So I was hoping you could kind of start us out on what that drug is and kind of mechanism of action and maybe walk us through that.
Yeah, so I think it's pretty cool. We have another new drug for ocular surface disease and dry eye. And for once, it's not an eye drop. It's, nasal spray. So that's a very new kind of novel thing for eye care that we're prescribing something that you actually stick up your nose, I guess. So it's really cool technology though, when you really think of it and the science. And I think it's just something that as a profession, we really have to embrace because the way this works is just really, really cool. Unfortunately, we have to go back a little bit to our neuroscience days and just think a little bit about, the trigeminal nerve and the ophthalmic branch of that and how it innervates the lacrimal functional unit. And that's really how all this kind of works and is tied together. And in a nutshell, and we can dive into this a little bit more, but in a nutshell, the drug stimulates that lacrimal functional unit, and it stimulates all 3 layers of our tears. So it stimulates, the meibomian gland, it stimulates the goblet cells, and it stimulates the main lacrimal glands to produce all 3 layers of our tears. So that's what I just think is really cool about this.
Well, and I think that it brings up a really great point when you say that, is that it's, really just thinking about how important basal tears are. And here we try to substitute them with artificial tears to our patients. But, what's better than being able to have your patient make their own basal tears, and do that in a better way. So I find it to be really exciting for that reason too. I think some of the research around this also just really brought to light to me like how important the nasal pathway is for just basal tear production. One thing I didn't realize was just the simple act of breathing is producing a third of the basal tear, which I thought was pretty interesting. Just you breathing over that trigeminal nerve is responsible for a third of the basal tear.
Yeah, that's really interesting. In fact, I think I read a study that when people sleep, and people who are more nasal sleepers than sleeping with their mouth open and breathing while they're sleeping that way, that they actually have this increased amount of basal tear production while they're actually sleeping, which is just really, really cool. Because like you said, anything we can produce that's natural versus anything artificial is just going to be better. And it's going to complement, I think, anything else we're doing to treat these patients.
Well, and the other thing I think that's really unique about you and having you on to kind of talk us through this whole LFU unit and how do we stimulate it is you have a lot of experience with other mechanisms, neurostimulation and how that worked for your patients, which is addressing as the similar pathway, but now we're just using a different approach. So maybe kind of talk us through even, how True Tear worked for your patients and, where you think that Tyrvaya is going to fit, with your history in that whole neurostimulation kind of area.
I thought True Tear when it came out was really cool. To have, neurostimulation goes back many, many years, and we know it's good for a lot of things, brain injury, spinal cord, all sorts of different types of injuries. But, for eye care, this neurostim idea at the time was just so interesting. And the fact that you could, electrically stimulate, that pathway of the LFU, was so cool to think about. And it really worked. I probably had about, 40 to 50 patients who religiously used their True Tear devices a couple times a day. And I remember when it first came out, I almost couldn't believe it worked. And I would have patients while they're in the slit lamp. So just think their heads in the slit lamp, and I have them contorted, holding the nasal stim device in their nose, trying to stimulate themselves so I can look in the slit lamp and actually watch the meibum coming out of their meibomian glands. It was really the coolest thing to actually watch. You actually see the meibum coming up through their glands, and this kind of new oily material on the lid margin. So, when I saw that and I saw it worked and I saw patients doing well with it, I knew we had something here. So, once we got past the whole thing of inserting a device into your nasal passage and dealing with everything that went along with it, possibly sneezing and all, we had great results with it. And it was unfortunate that, it kind of went by the wayside, and the company that had Allergan didn't continue to kind of, sponsor it and take care of it, kind of went by the wayside now. But now we have the same technology, but a different delivery system. So it's really, I think, pretty cool for our profession.
Do you, Tom, have anyone on iTier 100? That's like a lesser known, neurostimulation. Have you seen that device?
Yeah, I've seen. I just don't have anyone on it yet. I just haven't been able to dive into that. When I actually didn't even know about it, and then a friend of mine, Jen Randall, kind of messaged me on Facebook and said, "Hey, Tom, I've been using this," and I started to look at it, and then Tyrvaya came out, and I'm like, "Well, let me kind of dive into this." And so I think at some point I may look at that, but it's just it is nice to have that.
Yeah. Can you talk a little bit about your patient selection for Tyrvaya, and are these patients, switching from a Restasis or a Xiidra or Cequa and going on to Tyrvaya, or, what is your experience sort of shown?
So right now, and I probably have maybe 20-ish patients using Tyrvaya right now. What I've been doing is it's patients, most of them are patients that are already on a Restasis, Cequa, Xiidra, and let's say omega-3s, and they're still maybe need something more. They're using artificial tears a lot, and they're just, not where we want them to be. And now this is an option that I'm adding. And the way I'm explaining it is just, this natural tear production. Maybe we can get you off something in the future. I was able to pull some patients off medications when they were on the True Tear in that segment of patients. Let's say they were on Restasis and Lotamax and Doxy, things like that. I was able to get them off their Lotamax or off their Doxy or something like that. But so we may see that happening. It's just, we'll see how well it works. But the results so far have been pretty good.
Yeah, I think, I mean, I certainly don't have the sample size that you have. I have 3 patients on it at the moment, or 4. Maybe I just started another one today. But you know, it's interesting to see that you can really combine that with other therapeutics like Xiidra and Restasis. It's a totally different mechanism that we're sort of going for. So it's nice to be able, and I kind of foresee that same thing, maybe you know, being able to pull off one therapy. If I start them on, you know, Tyrvaya, that I can sort of pull off the other, or really just use them in conjunction and make the patient a lot happier.
And so I think the other cool place I think it'll be is just think, you know, a lot of our OSD patients have just surfaces that are a disaster. And as soon as we try to put something on it, you know, their osmolarity sky high, you know, we try to put any sort of drug on that surface, they go crazy, burn, sting, they can't stand it. They're just non-compliant because of that. So here's something that we're not touching the ocular surface, and we can get the same effect, if not maybe better. I don't know. We'll see. But I just think that's the real cool thing about this too, is we don't have to touch the surface at all.
So the patients that you have on this so far, are you doing 1-month follow-ups to see how they're feeling? Like what's been or has it been out long enough for you to do a 1-month follow-up?
Yeah, you know what? I haven't. I've seen one patient back in follow-up. I've done 2 kind of phone calls. They were early patients. I said, I want you to call me in like 3 weeks and just tell me how you're doing. Mm-hmm. And one actually forgot to call. So I called her and she's like, no, it's going good. And I'm like, okay. So it's weird because like we were talking before, you know, we start someone on a new medication and we get like 5 or 6 calls of issues. I haven't heard that yet, which is a good thing, I guess. Unless I get 15 calls tomorrow, then you know, then we're in trouble. Yeah, so far it's been pretty quiet, which is good.
Yeah, I've had the same experience too, where I think when I was talking with my rep, he, you know, they always say, oh, the coverage is really good. I'm always like, okay, yeah, we'll see. You know, what sort of, you know, prior auth do I have to do? But I've had to do nothing for my patients so far that I've put on this. So I've had the same experience.
Well, that's good. I haven't actually, I have given samples and haven't prescribed yet. So good to know that, you know, it will be easy when we get to the pharmacy. But I also have not gotten a lot of callbacks. I actually haven't got any callbacks, which I agree with Tom it's kind of quiet and I'm not used to that. So that's exciting, for sure. I wanted to hear what your thoughts were on just how are you having a patient utilize it the first time? You know, with this medication, there's certain things that are going to make it more successful, I guess, with the newly out of the box. One is priming that pump like 7 times. So I've done that in the exam room, shown the patient that with the sample, and then have them do one administration in the office. Have you done that?
Yeah, that's pretty much exactly what we do. I'll actually open the box up right in front of them. That's the other good thing is we've had a lot of samples. The company's pretty good at this point of getting a sample. So I'll open the box. I'll show them. You take the blue cap off. You have the little safety piece there so it doesn't discharge on its own. I'll show them how to prime it. And then I will actually, you know, tell them that you don't want to go straight up and inhale. You actually want to angle it so it's angled to the top of your ear. So I'll tell the patient, you know, for your left nostril, use your right hand, right nostril, left hand, and I'll actually do one of their nostrils for them. So I'll actually show them, here's where you want to do it, and I'll discharge it, and then I'll say, now you do the other one, and I'll have them do it. And the one thing we just have to watch for is some patients, they'll sneeze. This, just like the TruTear would cause that sneezing reaction. The patients will sneeze maybe once, or my record is 18. One patient sneezed 18 times, real fast in a row, and then she was done. But it doesn't last. It's just kind of, and then it's over. And she actually called me about 4 or 5 days later and said, I only sneezed twice. So I think that reaction just kind of subsides as time goes on. So I kind of show them right in the office. And then what I usually do is I prescribe it actually at that visit. because I have found that it takes a couple days for the pharmacy, if there does have to be PA done or anything like that, for that to happen. So I want to make sure that as they're using it, if they're going to do well, that that whole process is started.
I do the same thing. I just send it right to the I say, let's start on this. Here's the sample, but I'm just going to send it into the pharmacy. But I do not do the in-office trial of that. Maybe I should do that.
Well, the big thing is, I mean, they have that tear-off sheet that's really helpful, but I think even even the way that it depresses, I think if the patient doesn't push it hard enough, nothing releases. So they might not be getting anything. I like to show them even just how to get the solution out. So I think you might want to start doing that. That would be my advice, maybe once or twice with patients and just see how they do. But
and even the priming, Leslie. So what I'll do is I'll prime it 4 times and I'll say, now you do the next 3.
Yeah, that's smart.
So they get the feel of kind of how to press down on that ball. Because you're right. If they have arthritis or something, they don't push down hard enough, they're just not going to get it.
Yeah. And then the only thing I guess that is, to maybe Jackie not trying it out in the office is it's a little bit underwhelming after you get through the sneeze, that first, the first administration. It isn't like they feel or look teary-eyed, right? And so I just guided the patients that I've started to say, this is how you do it. And then I'll see you back in a month and see how things are looking, because the data was looking at 28 or 30 day Schirmer data. So it wasn't that immediate response. So I wasn't discouraged by that, but I, didn't want the patient to think that immediately they were supposed to be getting like a tearing reaction.
And I think with anything in dry eye, this is a little bit of hand holding, because we have to set our expectations no matter what it is. So exactly to your point, I'll tell them, listen, you are not going to go home and feel fantastic today. This is going to be one of those things that you're going to wake up in 2 to 3 weeks and be like, you know what, my eyes feel better today. And they feel a little bit more moist. It's a very kind of gradual type increase, which is what I think the data kind of showed.
Well, and then the one thing I definitely have to ask you, Tom, and is, have you tried it on yourself? Because I know that you always are talking about you yourself, the dry eye patient.
I have, let's see, I've done it. I haven't been as vigilant with it. I probably should. I did not have the sneezing reaction, thank goodness. But it doesn't. It leaves a little weird taste. At maybe after about 5 minutes later, you can just taste it a little bit. But the real key for patients, if you really don't position it right and you go more straight up, it does feel a little like kind of cool sensation, like peppermint patty sensation type. So I think it is important that you just kind of go definitely on an angle and not straight up the nostril. So I'll see how it goes over the next couple of weeks and see.
I did the same thing. I tried it on myself, and I did not sneeze, even though, I mean, in the clinical trial, it was like 81% of people report sneezing after. So it's a super high number, but I didn't notice any sneezing, but I did notice like a little bit of a burn. I'll call it menthol. I kind of like your peppermint patty analogy, but it was a little bit of that in the nose and then a little bit in the throat for me personally. Did you try it, Leslie?
I have not, because I unfortunately did not get as many samples as you, Tom. So I was saving them all for patients, but I think I just got more maybe later last week. So it is my turn to finally try. So I'll let you know.
I think the one thing we should talk about is maybe the prescribing it and how it goes. They're using the one pharmacy. It's called PhilRx out of Ohio. So it's not something that you just write it or e-prescribe it to your local pharmacy. It does go to that PhilRx in Ohio. And what I have to say is they've been really good. I actually did a prescription for my wife, and because I wanted to see how it went. And within about 6 hours, she got a text message from PhilRx, and it said, you were prescribed this. Do you want to proceed? And you just click on the text message, yes. And then it walked her through, here's your insurance information. Her insurance information was sent right through our EMR. So they had it and they verified the insurance information. And then there was a couple prior authorization text messages back and forth and email to confirm. And that was the process. They did all the legwork. My staff didn't have to do a prior authorization. There were no letters to write. There was no showing failure. It was pretty smooth. So that seems to be a good thing.
Yeah. Yeah, I actually kind of like when they have their own pharmacy, like in the same way that like RVL's pharmacy is really simple. I sometimes feel like I get more callbacks or have more issues when it's a CVS or a Walgreens. So I have not been as paying as close of attention as you have, Tom, on like how it's going, but I don't hear anything from my staff, so that must be it's okay. They'll usually tell.
Unlike a baby, silence can be a good thing. They always say, like, if it's too quiet with your kids, something bad happened.
Yeah.
But I think with, in our lives at work, I think a little bit of that is appreciated, right? We do so much effort to get medications through. Exactly what you said about a different delivery route, not the ocular surface when it is so inflamed, it's going to really go a long way for patients' tolerability and hopefully adherence.
Yeah, I think this is just a really exciting time, for our profession. I hope our profession embraces this. I know TrueTear, and again, there have been just, the whole device in the nose thing that we didn't embrace. But I think this is something that we hopefully do embrace, because I think it could be really a game changer for a lot of patients. Exciting time for our profession.
It is. What has been your patient's reaction when you tell them that this is like something that it's a nasal, applicator? Like, what has been the response?
It's actually been much better. They'll actually say, so I don't have to put another drop in. Yes. And it's only twice a day. Yes. That's great. Let's try it. So I think it really helps with compliance, because, for me, I'm a big Lotamax Restasis person, twice a day, both drops 5 minutes apart. This is much easier for the patient. So it's, quick, boom, boom. You don't have to wait. You're not blurry. You're not teary. You're not watery. You don't have to worry about driving and not being able to see or whatever. So I think this just may help with that, with compliance.
And when you said that, the first patient that popped into my head would be a glaucoma patient, right?
Mm-hmm.
So here's a great ad for all of our glaucoma patients with ocular surface disease, that we aren't going to confuse their glaucoma regimen while we are treating the ocular surface.
And think of our glaucoma patients, mostly Medicare patients, and we always think new medications not covered well. 3 of my patients have been Medicare, 2 got it for $10. So I think, again, the company does a pretty good job of getting the prior auths and doing what they need to do. So that's a good thing.
Yeah, that's great.
All right. Well, thanks so much, Tom, for coming on to talk about Tyrvaya. This is certainly an exciting new product, new mechanism, of action that we're all kind of excited to try. So thanks for giving us all of your experience using the medication.
Welcome. Thanks for having me on. I really appreciate it. It's great.
And now for the To The Point wrap-up. When treating your dry eye patients, one of the biggest challenges can be burning of the eye drops we prescribe on that inflamed ocular surface. Well, now we have our first FDA-approved nasal spray delivery for our dry eye patients with Tyrvaya. This medication triggers the parasympathetic system through the trigeminal nerve to increase your patient's basal tear production. A great addition to the toolbox for your dry eye treatment.